The best practice is the lowest effective dose, your third psychiatric consultation. Today, I'm going to address the issue of the number needed to treat, the NNT. That is the number of patients you have to treat with a psychiatric medication for one patient to get better. I suggest that the reader review the post by the former NIMH director Thomas Insel, Antipsychotics, Taking the Long View by Thomas Insel on August 28, 2013. That will get some context for this conversation. Let's look at the number of needed to treat NNT for one patient to get better. These numbers are hard to find for psychotropic medications, so I will use statins as an example. 60 people have to take statins for 5 years to prevent one heart attack. 260 people have to take statins for 5 years to prevent one stroke. The annual cost of statins is $600 to $1,000 per subject. In addition to the cost of the medication is the cost of the lab tests and office visits. During those 5 years, patients suffer from muscle pain, fatigue, weakness, and rhabdomyolysis, which can result in kidney failure. That is a side effect of the statins. Log on to the internet and read, quote, "What are the odds that your medications will help you get better?" by Sharon Begley. This was published in 2019. The number needed to harm is even more difficult to find. However, read the FDA prescription drug labeling. It will list side effects and percentages of patients with each side effect. That is a good proxy for the number needed to harm, or NNH. Let's look at the CATIE trials to grasp the reasonable expectations for benefiting from antipsychotic medications. This trial compared 18 months of treatment of perfenazine against 18 months of olanzapine, quetiapine, risperidone, or ziprasidone. Only about 25% of patients in the CATIE trial completed the 18-month trial on the medicine which they were assigned. That indicates that in general, psychotropic medications are not very effective. The dropout rate is rounded to the nearest 5% as follows: 65% for olanzapine, 75% for perfenazine, 80% for quetiapine, 75% for risperidone, and 80% for ziprasidone. From the point of view of the patient and the physician, there is no meaningful difference in benefit among these medications. Their usefulness is a disappointment with substantial burdens. Clozapine is the gold standard for the treatment of schizophrenia because of putative additional benefit with better improvement of social function. Let us look at the research that allowed clozapine to be marketed for the treatment of schizophrenia. Examination of the Clozaril FDA label reveals black box warnings for severe neutropenia, orthostatic hypotension, bradycardia, syncope, which is loss of consciousness resulting in falls and injuries, seizures, myocarditis, cardiomyopathy, mitral valve incompetence, and increased mortality in the elderly with dementia. The reader should be advised that the warning advises of increased death in the elderly with dementia. This is the narrowest interpretation of the research. This research was on the elderly with dementia, not on the elderly with and without dementia. There is no rational basis to think that the elderly without dementia with exposure to Clozaril are safe. Risk management and common sense would dictate that the above warning should be written in broader terms. The elderly are at increased risk of mortality, with the possibility that further research will reveal that the elderly without dementia may not be at increased risk of death. Further examination of the FDA labeling reveals that the medication was released based upon a mere 6 weeks trial comparing Clozaril to Thorazine, also known as chlorpromazine. The measure used was a 20% reduction of symptoms. 20% was considered a clinically significant improvement. 40% of the Clozaril patients had a 20% reduction in symptoms after 6 weeks. That means that 60% of the patients treated with Clozaril did not achieve a clinically significant 20% reduction in symptoms. This compares to 4% of the chlorpromazine patients achieving a 20% reduction of symptoms. A 20% reduction in symptoms leaves 80% of the symptoms for the patient and the family to deal with. In a 104-week study comparing Clozaril to olanzapine, there was a 24% recurrence of suicide attempt or suicidal episodes for Clozaril compared to a 32% rate of recurrence of suicide attempt or suicidal episode for olanzapine. The difference was 6% less suicidal episodes for Clozaril as compared to olanzapine. The absolute reduction is 32% over 2 years. You would have to treat 3 people for 2 years to reduce suicidal episodes by 1. For Zyprexa, you would have to treat 4 people for 2 years to reduce suicide episodes by 1. In the case of depression and suicidal episodes, clozapine is clearly indicated if the patient is willing to accept the risk of side effects. The medical literature in general supports Clozaril as superior to all other antipsychotics, and therefore Clozaril is the gold standard for treating schizophrenia. In particular, Clozaril is touted as the antipsychotic that improves social functioning in addition to suppressing hallucinations, delusions, and paranoia. However, meta-analysis of the medical literature, including Cochrane reviews, reveals many flaws in medical research. Among those flaws are publication bias, short duration studies, and poor quality in data collection. Recent literature reviews have found that Clozaril does not improve social function. See Clozaril and psychosocial function in schizophrenia, a systematic review and meta-analysis. This was published in 2018. There are reviews that reveal that Clozaril, also known as clozapine, is not superior to other antipsychotics. See efficacy, acceptability, and tolerability of antipsychotics in treatment-resistant schizophrenia, a network analysis. There are articles that indicate that Clozaril is superior to other antipsychotics, but only 40% achieve a benefit, and augmentation with aripiprazole, fluoxetine, and sodium valproate may provide additional benefit. See augmentation strategies for clozapine refractory schizophrenia, a systematic review and meta-analysis. This was published in 2018. Now let us look at the medical literature for medications used to treat depression. In general, medications used for depression also improve anxiety and panic attacks. Review of the literature reveals serious weaknesses in the research, and there is a strong possibility that there is only a small benefit as compared to placebo, and the benefits are inflated. See, considering the methodological limitations in the evidence base of antidepressants for depression, a reanalysis of a network meta-analysis. This was published in 2019. Another review reveals only modest benefit of antidepressant medications. If 100 is complete relief, the medication effect is 30, with 70% of the symptoms remaining after medication treatment. Efficacy and acceptability of antidepressants in acute depression. What does the largest ever research study on antidepressants tell us? This was published in 2018. The placebo effect is equal to 75% of the antidepressant medication effect. That means a sugar pill without medication is 75% as effective as medications prescribed for depression. See antidepressants and the placebo effect, published in 2008. In fact, most of the benefit of medications for treatment of anxiety and depression is placebo effect and not medication effect. See placebo effect in the treatment of depression and anxiety. This was published in 2019. A placebo has no medication and no significant physiologic side effects. Placebos have substantial psychological effects, including relief from pain, anxiety, depression, and other symptoms. The idea that there is a treatment and the expectation of getting better overcomes the idea that there is mental illness and the need for treatment. Regardless of the psychotropic or the mental illness, after the failure of the first trial, it is necessary to increase the number of patients treated with each medication increase or medication change for one patient to get better. My takeaway from this is that less medication and more psychotherapy, more meditation, more physical exercise, more healthy eating, more learning, more social engagement, more charity, more fellowship of mankind, more treating others the way you want to be treated. I am here to do no harm and help if I can. Be kind and you can be my friend. That's the end of this book. Tomorrow, I will start my 4th psychiatric consultation book. I forgot what the title is. You'll have to wait tomorrow for me to read the title to you. Thank you for your time and your kindness. Have a great day.